Science and Seno Medical present Opto-Acoustic Ultrasound, a new hybrid modality for breast cancer diagnosis. Speaking on this topic today is Dr. A. Thomas Stavros. Dr. Stavros is a women's imaging radiologist and chief medical officer at Seno Medical. He has been involved in mammography since 1976 and has been actively involved in the development of high-frequency handheld breast ultrasound since 1981. Dr. Stavros' main interests are general ultrasound, breast imaging and intervention, and ultrasound-guided FNA and/or core biopsy in the thyroid and head and neck. He is a reviewer of several medical journals. He has written or co-authored numerous articles, including the definitive textbook for reference and learning in the specialty breast ultrasound. At any time during the webinar, if you have questions, please type your question into the Q&A at the bottom of the control panel. Questions will be addressed live at the end of the webinar. A recording of this webinar will be sent to you via email. If your question was not answered at the end of the webinar, please send them to info@cmescience.com. If you would like to learn more about Seno Medical, please visit their website, experienceimagio.com. Thank you again for attending, and we hope you enjoy. If you would like to see Dr. Stavros speak live, he will be at our Advanced Breast Imaging course in Las Vegas, January 27th through the 29th, 2022. Join us in person or via live webinar. Please go to cmescience.com for more information.
Hello, everybody. Glad to have you all here. I'm Tom Stavros, and my disclosure is that I am the Chief Medical Officer of Seno Medical Instruments, who makes the Imagio optoacoustic device that we're going to be talking about today. So we're going to talk about challenges of breast imaging and why optoacoustic imaging is necessary as an adjunctive diagnostic test. We're going to talk about what optoacoustic imaging is, and how the laser and ultrasound fusion works, and we're going to talk about our 6-on-1 display. And we're going to talk really a lot about the importance of looking outside of what the BI-RADS considers the mass. The hypoechoic mass is just what we consider the internal zone, the central nidus of the tumor. BI-RADS 5th edition got rid of the boundary zone, which turns out to be the most important zone. So we're going to talk a lot about that. And then the peripheral zone is also very important, especially for prognostic biomarkers. We're going to talk about why we store video loops rather than still images, how OA differs from Doppler, and we're going to show you a very brief introduction to distinguishing benign from malignant. And we're going to talk about how artificial intelligence, machine learning, has helped us in the process of using OA. Using OA is actually a two-step process. The first is done entirely with the eyes and brain. The reader, the breast imager, has to recognize the features that are present and score them properly. But the second step is converting the good feature scoring into a likelihood of malignancy or a predicted false negative rate. Now that step is the step where artificial intelligence hurts. Then we'll talk about a summary. So one of the big challenges of breast imaging today is the so-called harms of screening. And they arise because we create a lot of false positives. So we have adjunctive tests like diagnostic ultrasound to help us sort through those and diminish false positives somewhat over what we get with mammography. But the problem is ultrasound is based entirely upon morphology. And there's so much overlap in the benign and malignant features of breast masses that we can only get so far in terms of improving our diagnostic abilities with ultrasound alone. And we'll talk a little bit more about that in detail. So we think one way to overcome this problem with the morphologic overlap is to add a functional component. And so the optoacoustics is actually a functional component in addition to ultrasound. And it's very similar to other fusion technologies like PET-CT or PET-MR or multiparametric MRI that use contrast or radionuclide to show the functional component. We don't need those things. PET-CT and PET-MR are very expensive, and it's hard to get them approved. Now, OA was developed to give us a combined morphologic and functional imaging test that was more affordable than the currently existing functional imaging tests. It's important to understand that cancers can't grow beyond 2 millimeters in size without generating neovascularity. And this vascularity occurs not just within the hypocentral nidus, but as I mentioned, outside of it in what we consider to be the boundary and peripheral zones. And OA can demonstrate the presence or absence of angiogenic vessels or physiologically enlarged vessels or even normal vessels. And it can also show the morphology, which differs between benign and malignant. It's also true that cancers are generally, not always, but generally more metabolically active than benign tissues or normal tissues. And they create more deoxygenation. And one of the functional things, or the best functional thing that we detect with optoacoustics, is relatively greater deoxygenation that occurs in the surrounding normal tissues or would occur in a benign lesion. So this is just a schematic showing a small cancer growing on the left. Say that's a millimeter, too small to have generated angiogenesis. The middle, my cursor is showing maybe a 2 millimeter cancer just beginning to develop neoangiogenesis. Now at this point, there may not be enough neoangiogenesis to be detected by OA. It has to be a certain amount. On the right maybe is a 4 millimeter nodule. And now there's enough angiogenesis that OA can demonstrate it. So the smallest cancer we've seen with OA is 3.5 millimeters. So it's in between these two sizes on the right. So what is optoacoustic imaging? It's a dual fusion imaging. It's a fusion of modalities. We send laser light in and receive ultrasound back out. But it's also a fusion of morphology and a function. Actually, that should say function. The morphology comes obviously from grayscale ultrasound, which is fused in real time, but it also comes from the OA demonstration of vessels and their morphology, which helps us determine whether they're malignant neovessels or some sort of normal inflammatory vessel or just plain old normal vessels. The function comes from the relative degree of deoxygenation that we see within the lesion. Now, why did we choose to put laser together with ultrasound? Mostly because it's more affordable. It would have been theoretically possible to have laser combined with CT or MR, but then it wouldn't be as available. It'd be too expensive, and we'd have all the same access issues we have with MR. Now, other functional imaging tests that exist now include contrast-enhanced MR and VSGI, which uses radionuclide, which is radioactive. MR requires contrast injection. PET, CT, or PEM requires radionuclide with a pretty high dose of radiation, not just to the breast, but to the entire body, including the bone marrow. And then there's contrast-enhanced digital mammography, which is functional, but again, you'd rather not have to use contrast for the number of cases that require diagnostic ultrasound. Now, this is a contrast-enhanced, ultrasound contrast-enhanced examination of a grade 2 cancer. And you're beginning to see the cancer fill. It's in the center, and you're seeing some peripheral radiating vessels feeding and draining it. And if I draw in a region of interest, inside that white dotted line is the internal zone, what the BI-RADS considers to be the mass. But you can see a tremendous amount of this neovascularity is occurring outside of what we consider the mass. In fact, the vast majority of what we recognize as morphologically abnormal vessels, these would be boundary zone whiskers on the left, little short neovessels that are oriented perpendicular to the surface of the internal zone and the boundary zone, and peripheral radiating vessels farther out from the boundary zone. So morphologically abnormal vessels. So can you see what we see with OA with contrast-enhanced ultrasound? You can, but it has to be done in the accumulation or persistence phase. You can't perceive all of these findings with just real time. And also, again, it requires an ultrasound contrast agent, which only recently was approved. I mean, it was just approved like last year or the year before. So the advantages of OA combined with ultrasound is we don't have to inject any contrast or ionizing radiation. We have the high spatial resolution of ultrasound, which is below a millimeter, usually within the optimal focal zone, somewhere in the 300 to 500 micron range. Outside the optimal focal zone, maybe a millimeter. It's present in every breast department in the United States or outside the United States. And virtually every breast imager has to use ultrasound. So they're familiar with the user interface and how to do it. This is a schematic showing a handheld duplex ultrasound probe. I'll show you another picture of that later. One of these cords is a fiber optic cable bringing laser in, and the other is an ultrasound cable with the ultrasound wires, electronics. So what we do is we send in brief pulses of laser at 2 different wavelengths designed to be absorbed in blood, oxygenated, deoxygenated blood. That causes thermoelastic expansion of the blood vessels within the breast. And the expansion of the vessels sends a pressure wave back to the ultrasound transducer, which really can't distinguish pressure wave from an ultrasound wave. So it interprets the expansion wave coming back from the vessels as ultrasound. So it's laser in, thermoelastic expansion, ultrasound back out. This is done at very low frequencies. So say we're doing breast ultrasound with a 5 to 16 or 5 to 18 megahertz transducer. We can just expand the bandwidth at the lower end. So we go all the way from 1 megahertz up to 18 megahertz. And then we can pick up the pressure waves coming back, which are at lower frequency than we usually do breast ultrasound at. This is a schematic. Brown is the absorption in deoxygenated hemoglobin. Red is the absorption in oxygenated hemoglobin. We can see very clearly that there's a peak at 757 nanometers for deoxygenated. And so we've chosen 757, but you don't need to remember the number. Just remember that shortwave is going to be shown as red, and it's going to represent the deoxygenated blood. Red, like the red light on a stoplight. The longer wavelength, 1064, was chosen not because it's the peak of hemoglobin, because it's the widest separation between oxygenated and deoxygenated. And it also avoids a confounding water peak, because water and fat can also contribute to optoacoustics. And it's going to be demonstrated as green. So we have a color scale. The fuchsia and red end is the deoxygenated end, and the aqua and green end is the oxygenated end. So again, this was originally designed to be as simple as a stoplight. Green means go, you don't have to worry. Red means, you should worry. But that was just a general rule. And in fact, that's just a functional rule. You still have to look at the morphologic rules. So I'm going to talk more about red versus green and morphology, and when to weigh most importantly. So again, the morphology that we see with optoacoustics is obviously going to come from ultrasound, which has always shown us morphology. But it's also going to come from the demonstration of blood vessels and their morphology. And the morphology is going to tell us whether they're suspicious for malignant neovessels or whether they're probably just inflammatory hyperemia or just normal vessels. So here we're seeing a case of a small 6 millimeter grade 2 invasive ductal cancer. And I've drawn the 3 zones in. So what the ACR considers the mass, the hypocoax central nidus, what the mass is in BI-RADS is just inside this white line. The thick echogenic rim represents the boundary zone. And out here we have the peripheral zone. We can see there's interrupted tissue planes and hypercoax spicules in the peripheral zone and the thick echogenic rim in the boundary zone. On OA, we can see there's a lot of red in the internal zone and a red blush in the boundary zone. And we can see that there are green vessels that are oxygenated, that are radiating, which means they're parasitized native vessels. Tumor vessels are usually red, but parasitized native arteries can be green. So we're seeing findings in all 3 zones in this grade 2 invasive ductal cancer. Intense deoxygenated blush in the internal and boundary zones, and peripheral radiating green vessels. They can be red or green in the peripheral zone. Now, what does this blush mean? Do I see a discrete vessel? No, but we've done a lot of histologic correlations, and we've shown that the blush occurs when there are innumerable tiny vessels, each vessel too small to individually be resolved. but the vessels are so numerous that even though they're too small to be seen individually, they volume average to light up several adjacent voxels, and they create this red blush. So the red blush is due to innumerable tiny tumor vessels too small to resolve individually. So again, here's a case where morphology and function agree, they're concordant. We don't have any problem here. This is suspicious. It's got a lot of red vessels, way too many red vessels inside the lesion, and they're quote unquote polymorphic. We have a tiny one next to a huge one, next to a medium-sized one. They vary in orientation, so size, shape, and orientation differ. In this case, this is a triple negative. Most of the findings are internal. Again, red is deoxygenated, and when they're morphologically abnormal, they vary in size, shape, and orientation at approximately equal depths within the lesion and intensely deoxygenated. That's suspicious. All right, here's the ultrasound machine, or the OA Imago machine. It looks like an ultrasound machine, and it's actually, the newer version is going to be smaller and lighter than this, but approximately 2/3 of what's in there is laser hardware. So about 2/3 of the hardware and weight of the machine is laser. Looks like ultrasound, but it's not. This is a big display. We have a very large high resolution display because we show our images 6:1. You can see that the control panel is very much like an ultrasound panel. You should be very comfortable with it. What you're seeing in the top center is the face of the duplex probe. The original one was 38 millimeters. The new one will be 50 millimeters. The ultrasound transducer is in the center. And there are 2 quartz laser windows out of either side, and both wavelengths are fired out of both. So the wavelengths are fired out through the laser windows. They cause a thermoelastic expansion when they're absorbed in blood vessels in the breast, and then the ultrasound detects the pressure waves coming back. This is a side view of the larger cable is the one that carries the fiber optics, the smaller carries the ultrasound information. Now, what I want to show you is that the machine has a regular standalone 5 to 18 megahertz ultrasound transducer. And this is important because there are 2 types of diagnostic ultrasound. One is the general entire group of diagnostic ultrasounds, of which, depending on your case mix, about 80 to 90% are BI-RADS 1 or 2. Let's just say 80% are BI-RADS 1 or 2. Well, the negative predictive value of a BI-RADS 1 or BI-RADS 2 ultrasound is so good, it's above 99%, that you don't need OA. There's almost nothing in radiology as good as a BI-RADS 1 or BI-RADS 2 ultrasound in a targeted diagnostic mode. Now, that might not be true for screening mode, but in targeted diagnostic mode, which is what we're talking about, a BI-RADS 1 or 2 is a pretty good gold standard. So the idea is you don't need 2 machines in a room. You don't need an ultrasound machine that does Doppler and elastography and all the other stuff, and an optoacoustic machine. You just need the optoacoustic machine with a standalone ultrasound probe. You do every case on this machine, and the 80% that are BI-RADS 1 or 2, you really only need the ultrasound probe if you want to. Now, could you do ultrasound only with the duplex probe? Sure. You can do ultrasound only. You can do shear wave elastography. You can do color Doppler, power Doppler. You can do all the things you do with a regular ultrasound probe, but you can't do them in triplex mode. In other words, you can't do color Doppler together with OA, together with ultrasound, or you can't do OA together with shear wave elastography together with ultrasound. It only works in duplex mode, so you can use ultrasound plus elasto, ultrasound plus Doppler, or ultrasound plus OA. But the bottom line is you can do everything in here, and the 20% of cases where you have a BI-RADS 3 to 5 solid mass, which is what OA is approved for, then you can use the duplex probe. Again, this is a bigger view of it, and you can see that this was a 38 millimeter transducer, but the newer transducer is going to be 50 millimeters, which is what we more typically use. Now, we fire ultrasound anywhere from 20 to 50 frames a second. We can only fire 10 laser pulses per second because we have to allow enough time between the pulse for the heat generated by the very brief low energy laser pulses to dissipate, to diffuse into the surrounding tissue, and also to be carried away by flowing blood. Most of what's getting heat is the blood, but as the blood flows, it's carrying the heat away. If we get a frame rate too high, then we can get heating. With the current technology, there's less than a 1 degree Fahrenheit change in the temperature, no matter how long we scan. But there is a discrepancy in the frame rate. It's slower for OA because we have to allow time for the heat to dissipate. So I'm showing you what looks like a blood vessel, this red thing on the right, transducer on the left. We fire the 2 laser pulses. They cause thermoelastic expansion of the blood vessel, which creates a pressure wave coming back to the ultrasound that the ultrasound probe detects as ultrasound. How long does that take? 200 microseconds. Obviously, it's going to be a little longer for deeper, a little less for more superficial lesions, but on the average, 200 microseconds. And we fire 10 pulses per second, but 5 is the short wavelength, 5 is the long wavelength. So since you need both a long and a short to create a single frame of OA, the actual update rate of OA is 5 frames a second. This is the display. This is the 6-on-1 display. The real-time ultrasound map is shown on the left upper corner. And then we have 5 OA maps. The 2 maps on the right are shortwave and long wave. So shortwave, remember, gives you deoxygenated. Long wave gives you oxygenated. So anything that's brighter on the shortwave is going to be colored red. Anything that's brighter on the long wave is going to be colored green. So these peripheral radiating vessels here are green, and the tumor vessels in the center, this grade 2 invasive ductal cancer, are displayed red. But these color maps are created by comparing the 2 maps here and then generating things off of that. And I'm not going to go into the details anymore. So what are the individual functional morphologic features we can see? Well, we can see the total amount of hemoglobin. If I go back to this previous image, the yellow map is total hemoglobin. So it's not telling you what's oxygenated or deoxygenated. It's adding the oxygenated and deoxygenated together, and it's giving you a total hemoglobin map. The OA relative is the most sensitive map, but it gives you more background signal. The OA combined is cleaner, better for downgrading benign masses, but it's filtered a little bit, so it's a little less sensitive. So there are, various uses for each. So the functional OA findings we see are total amount of hemoglobin, which is the yellow map, whether or not that hemoglobin is oxygenated or deoxygenated, which we can see on the red and green maps, and whether or not there's a blush, which we can only see on the bottom center OA relative match. The morphologic findings are the presence of absence of vessels and the morphology of those vessels. And what we look at is for, the diameter, monomorphism, vessels similar in size, shape, and orientation at the same depth within a mass, and irregularity, angles in the course of a vessel instead of a smooth curvature to it, or changes in caliber of the vessels, which can represent encasement. And these functional morphologic findings, we're not just going to look for them inside the mass. As I mentioned previously, we're going to look for them in the boundary zone, the peripheral zone. So when we learn how to maximize our sensitivity from the very beginning, I had to teach people that grade 1, grade 2, and grade 3 histologic grades look different from each other. Grade 1 is mostly boundary zone and peripheral zone findings, especially peripheral zone findings, often a paucity of any internal findings. Grade 3, on the other hand, has mostly internal boundary zone findings, but no peripheral zone findings. And grade 2s tend to be a mixture, more variable, but often have all 3 zones involved. Now, this is a cancer that had its feeding arteries and draining veins injected with latex rubber and then was dissolved with acid. So IZ means internal zone, BZ means boundary zone, PZ means peripheral zone. You can see that there are very few vessels in the internal zone. You can see that the richest vessels are in the boundary zone, but there are also some vessels in the peripheral zone. Now, most of the boundary zone vessels are neovessels. They're abnormal malignant vessels. Notice that most of them are oriented perpendicular to the surface of the nodule. We call those boundary zone whiskers. Notice that the peripheral radiating vessels are paired. That means they're parasitized native vessels. Tumor vessels are never paired. So most of the boundary zone vessels are neovessels, but you can see that there are some native vessels that are passing through the boundary zone there. And on the left at about 9 o'clock, there's one coming through. And then on the right at about 8 o'clock, there's one coming through. But most of the boundary zone vessels are neovessels. Most of the peripheral zone vessels are parasitized native vessels of the patient. But you can clearly see why we concentrate in the boundary and peripheral zone from this tumor model, because the vast majority of the vessels are in the boundary zone, with a fair number of the peripheral zone, and actually relatively little internal. Now, those of you who are doing breast ultrasound, either as sonographers or accredited mammographers, may just store still images, but the vascularity, the neovascularity associated with malignant lesions is often very eccentric. And this drawing illustrates very much that pretty much all the vessels are over on the right between 2 and 4 o'clock. If I just got a still image through this, 2 orthogonal still images, this vessel on the front of the nodule, the anterior surface of the nodule, the superficial surface, might appear to be a benign capsular vessel, and I would get a false negative. But if I make a short axis video sweep, meaning along the short axis of the transducer, to include a centimeter or 2 of surrounding tissues, then I pick up all this neovascularity. So we routinely score radial and anti-radial short axis sweep or longitudinal and transverse short axis sweeps in order to make sure we pick up this eccentric vascularity of the video loops. Now, again, when we first started doing this, I didn't do a very good job of teaching people how to look for the boundary and peripheral zone. And in fact, BIRAD's 5th edition strongly emphasizes the hypoechoic central nidus. It's completely gotten rid of the boundary zone. And the peripheral zone is there, but it's just described as associated features. And so most people who are doing breast ultrasound, radiologists, breast sonographers, mammography techs who are accredited to do ultrasound, tend to look for the hypoechoic central nidus. So I'm drawing in a white region of interest, and inside that is the internal zone, which is what BIRADS considers the mass. The thick echogenic rim, or the thin hyperechoic capsule in benign lesions, represents the boundary zone. And again, boundary zone was present in 4th edition, but they got rid of it in 5th edition, saying that it was too unreliable. We found it to be the best. And then the peripheral zone is whatever's outside the boundary zone. Now, one of the things we learned is that if we allowed people to score inside out, they stayed within their comfort zone, and they missed, the external features, which are primarily hyperechoic on ultrasound, the echogenic rim, and the spicules are usually hyperechoic. And so everybody's so focused on the hypoechoic central nidus and hypoechogenicity that they tended to miss boundary zone, peripheral zone findings too often. So we had a very simple solution. We just had people read peripheral zone first, then boundary zone, and then the internal zone. And lo and behold, they suddenly were picking up all these features. So if you force them to look for the white stuff first, then they can't ignore the white stuff. If you allow people to look at the black stuff first, then they tend to ignore the white stuff outside. Here's a scoring system for OA, and we have a very similar scoring system for ultrasound. There are 2 external features. Peripheral zone goes from 0 to 5, and capsular boundary zone goes from 0 to 6, and the 3 internal features that go from 0 to 5: internal vessels, internal total hemoglobin, and internal deoxygenated blush. So there are 5 scores that are assigned. Now, before we get into any more about that, I just want to, because we show blood with OA, people have this mistaken idea that this is just a super Doppler. That's an absolutely categorically and imperatively wrong way to think about this. Doppler can only see motion. So Doppler is angle dependent. If things are at 0 degrees, it sees it well. If they're at 90 degrees, it can't see it at all, no matter how fast it's flowing. Doppler requires a certain critical velocity. If blood flows too slow, it can't see it. You can't see blood flow in a placental lake with Doppler, but you can certainly see rouleau moving with the grayscale ultrasound. The big difference, I think, is a contrast ratio. This means that OA can tolerate a lot of volume averaging, whereas Doppler can't. What does that mean in practicality? Well, let's just say that a voxel is a millimeter. Because the contrast ratio in Doppler is maybe 1.5 to 1, if that vessel doesn't fill 90% of a voxel, it's just not going to show up on Doppler. It's going to, it's going to wind up with a contrast ratio that's below the noise threshold. On the other hand, OA can have contrast ratios anywhere from 6 to 20. So let's just take the example of a 20-to-1 contrast ratio. That means that a vessel can fill only 10% of a voxel, which is 100 microns in size, and still cause that voxel to light up with a 2-to-1 contrast ratio. So the reality is that a vessel has to be about 1 millimeter in size to be seen with Doppler, but we can see vessels 80, 90, 100 microns in size at the optimal focal zone in the cases with higher contrast ratios. So this is the same 6 millimeter invasive ductal cancer, grade 2, essentially false negative on Doppler, nothing inside. Tremendous internal and boundary zone blush and peripheral radiating vessels. It's 4+ positive on OA. And the bottom line is this degree of discrepancy is the rule, not the exception. And the final thing is we can show deoxygenation with OA where Doppler can't. This just shows a rabbit model of a cancer, and you can see how slow that blood flow is. There's no way that Doppler would show flow that slow, but OA can show stationary blood and much smaller vessels, so OA would show that. So here's a benign fibroadenoma, and this brings up a dilemma that often occurs. We showed you how grade 1 cancers often have a lack of internal findings, but really pronounced peripheral zone findings. And triple negatives have a lot of internal findings, but absent peripheral zone findings. So those are discordances. The other discordance that can occur is that, red is worrisome. It's deoxygenated. But you have to remember that every living tissue and every benign lesion has both feeding arteries and draining veins. And in general, arteries are going to be displayed as green. And in general, veins are going to be displayed as red. Now, the colorization is relative, so that doesn't happen 100% of the time, but it's a good general rule. So just because a vessel's red doesn't mean it's cancer. This is very much like MR. In MR, you have kinetics and morphology. And when they are concordant, when they agree, no problem in the interpretation. When there's discordance, say the morphology is suspicious and the dynamics or kinetics are reassuring, then you have a discordance and you have to decide which to rely more heavily upon. It's exactly the same in OA. This is a red vessel, but it's perfectly benign morphology. This is a draping capsular vein. It's a vein draped over the back of this benign fibroadenoma. So worrisome color, reassuring morphology. Morphology wins. You call this benign, even though it's red. And it's, again, anybody who reads MR, it's the same kind of rules. Morphology trumps kinetics when there's a discordance. These are other fibroadenomas, and you can see they have these classical draped capsular vessels. This is a small fibroadenoma on the right with an anterior capsular vein, and this is a larger fibroadenoma on the right with a capsular artery, with the OA combined map on top and the OA total hemoglobin map on the bottom. Same thing, I'm just simplifying it by getting rid of the other 4 images. Now, for OA to be effective, it's got to help us sort through screen-detected lesions. On mammography, the screen-detected lesions are going to be, in the 1.5 centimeter range. On diagnostic ultrasound, they're going to be in the 1.2 centimeter range. In screening ultrasound and in MR, they can be under a centimeter in size. So if we're going to help sort through all these small lesions that we're picking up, especially with supplemental ultrasound and MR, we have to be able to diagnose lesions under a centimeter. So this is a tiny this is the smallest cancer we've seen. This is a 3.5 millimeter grade 1 invasive ductal cancer. The hypoechoic central is there. The thick echogenic rim is there. So between the aqua and white lines is the boundary zone. Inside the white line is the internal zone. And outside is the peripheral zone. So notice there's absolutely nothing inside. All 3 internal scores are going to be 0, false negative. But the boundary zone is a blush, which is a maximum score of 6. And there's peripheral radiating vessels surrounding the lesion. So that's going to be a maximum score of 5 on the peripheral zone. So totally false negative internal, true positive external. These are discordancies that the human brain has difficulty with. And that's part of the reason we've instituted AI machine learning to help convert these scores into a likelihood of malignancy. Notice that 2 of the 3 peripheral vessels are paired arteries and veins. And the other third is the third one is green. which means it's an artery. Again, tumor vessels are usually red. So, the fact that these are green or paired shows that these are parasitoid native vessels, not tumor neovessels. But again, in the boundary zone, there's innumerable tiny tumor vessels, too small to resolve, that are giving rise to this blush. And I actually have histologic correlations on this particular case. This is the grade 2. Again, it's positive in all 3 zones: blush, internal, and boundary zone, and peripheral radiating vessels. And this is a triple negative. Really intense deoxygenated blush internal, deoxygenated blush in the anterior boundary zone, but no peripheral radiating vessels, so false negative externally. I needed to teach people the difference in the grades in order to maximize sensitivity, but what we recognize now is that these become very powerful prognostic biomarkers. And what do I mean by that? Well, not only can we determine with some degree of certainty, not 100% of course, but these correlate very strongly with histologic grade, estrogen receptor status, progesterone receptor status, Ki-67, little less strongly with HER2, but also correlate strongly with molecular subtypes. So if I go back, the grade 1 lesion I showed you is typical of a luminal A cancer. Positive in all 3 zones is typical, with a lot of peripheral radiating vessels, typical of a luminal B with a high Ki-67, maybe 60 in this case. And this is typical of a mucinous or triple negative, with a lot of internal stuff, but not much peripheral radiating stuff. The encapsulated papillary also looks like this. So there are certain subtypes of cancer. So we can use the difference in OA features between different kinds of cancer, not only to improve our sensitivity, but to make prognostic indicators. So here I'm showing all 3 together. The top is a triple negative. The one in the upper right is luminal A, and the one on the bottom is luminal B. So the triple negative, positive internal, positive boundary, completely negative peripheral zone. Upper right, luminal A, false negative internal, but really intensely positive boundary and peripheral zone. And the bottom is a luminal B, it's positive in all 3 zones. Now, I can't go through the scoring with you because it's like a 4-hour course for me to do that. But what we found in multiple studies that I'll show you a way to look them up at the end is that it was pretty easy to teach readers to properly score the ultrasound features. But the second step, converting good scoring into a likelihood of malignancy or likelihood of false negative, was far more difficult, especially in discordancies where, say, the external findings were positive, the internal findings were negative. The human mind has difficulty dealing with that. We really like everything to be concordant. In cancer, we want all the scores to be maximum, and in benign, we want them all to be 0. Well, that ain't the real world, unfortunately. There's just a lot of overlap, and there's a lot of discordances in the distribution of findings. And what's difficult for the human mind is not difficult for machine learning. So what we do is we put, the ultrasound scores and the OA scores and some non-ultrasound scores in there, and the machine will spit out a likelihood of malignancy or false negative rate. So we put 5 ultrasound feature scores in, 5 OA feature scores, and 4 non-ultrasound scores, which include age, mammographic bioreds, mass size, and depth of posterior margin of mass. And that gives us a single output of predicted likelihood of malignancy or false negative rate. Now, what's interesting is this could be expanded. I mean, you could have tyroacoustic scores in there. You could have race, whether they're black, who get more triple negatives, or whether they're Ashkenazi, who get more cancers, more triple negatives. So there's other factors that could be put into there, but they weren't in our database, so we couldn't develop that. But it certainly would be possible. This is the electronic data entry form for the Senogram AI machine learning thing. You can click radio buttons for the 5 ultrasound scores on top, the 5 OA scores in the middle, mammographic bioreds, patient age, mammographic diameter and depth, have drop-down lists. But what we found is that in the beginning, we had these hypertext buttons, the image reference keys. So you could click on an image reference key for the shape score. You click on this right button over here, just to the right on the space line, and it would bring up this image reference key with what kind of images, what kind of shapes correspond to what scores to help people. And they have colored frames, and these frames are color coded to the PPV. So you can see the color codes on the bottom. So blue means a low 4A, means BI-RADS 4A. And then for OA, the same thing. And we found, especially for OA, it helped people in the beginning to do this. Later on, after they got more experience, they could just race down and check it off. So it has a single output bar that goes from 0 to 100% with a big black line at 2%. To the left of the 2% line is the predicted false negative rate, and BI-RADS 3 and lower. And to the right of that line is BI-RADS 4A and higher, and where along that line you are determines how to assign BI-RADS. Now, we've got a lot of published articles from multiple studies, the Pioneer Pilot Study, the Pioneer Study, the Maestro Study, and the Reader O2 Study, and then some other general technical things. But we've gotten a lot of stuff in European Radiology, Radiology, and AGR. So these are published in major journals. Now, we did finally receive, after a 14-year slog with the FDA, we finally received PMA approval for OA, for Module OA, as an adjunctive diagnostic test, and specifically for masses, breast masses that are solid or complex cystic and solid, and our BI-RADS 3 through 5. Again, that doesn't mean you can't use a Maggio's ultrasound, a Doppler, and elastography for BI-RADS 1 or 2, or even BI-RADS 3, 4, or 5. But the optimal use for OA is in that subset of BI-RADS 3 to 5 solid or complex cystic and solid masses. So in summary, optoacoustics is a fusion imaging technique. It's somewhat analogous to PET-CT, but much cheaper and doesn't require any injected contrast agent. In fact, your own blood, the patient's blood, is an internal intrinsic contrast agent, so no radionuclide necessary. Are there contrast agents that are visible with OA? Yeah, some fluorescent agents will even light up OA more, but the goal was not to have to inject anything, and so we developed OA to be used without optoacoustic contrast agents. It's a fusion of a laser photonic light in, causing thermoelast expansion and being detected as ultrasound imaging out. But it's also fused and co-registered in real time with a grayscale ultrasound image. It's a fusion of functional and morphologic imaging. Again, the functional imaging is the relative degree of deoxygenation. The morphologic is the ultrasound plus the demonstration of the anatomy of the blood vessels and whether they're suspicious for tumor neovessels. The functional morphologic data are complementary, they're not just additive. And the net result that we got, the study that for which OA was approved is called the Reader O2 study, and it showed a significant improvement in specificity at exactly 98% sensitivity and better partial area under the curve between 95 and 100% sensitivity. And I don't want to go into that in great detail now, but it'll be covered in publications and in book chapters and whatnot. So the strengths of OA and ultrasound complement each other, and the weaknesses of OA are sort of handled by ultrasound and vice versa. The weakness of ultrasound are handled by OA, and that's why they're complementary. And this AI decision support tool, the Senogram, has really improved the second step of the process of converting scores into a likelihood of malignancy. Thank you. These codes, I forget what you call these, but if you store them, on the left will give you a list of our OA peer-reviewed publications in radiology and AGR and European radiology, and then some OA optoacoustics journals. And on the right, we'll give you the results of the Reader O2 study at clinicaltrials.gov. So I'm going to leave these up just for a second. Now, while I'm taking questions, I'm just going to show you, I'm emphasizing this is real time. These diagnoses can be made very quickly. You can see the video of this luminal B cancer, a larger luminal A cancer, again, mostly negative internally, but lots of red boundary zone whiskers. Those are short neovessels in the boundary zone oriented 90 degrees to the surface. This is a mucinous cancer, was much more suspicious on OA than ultrasound. This is what we thought was a benign papilloma, but turned out to be an encapsulated papillary carcinoma. And this really shows very well. See the intensity of the deoxygenation within this papillary lesion and how polymorphic the vessels are. So this was a case that was upgraded by OA. This is a grade 1 luminal B cancer. This was a triple negative African cancer. The point I'm trying to make here is this is real time. This isn't something that you process for 3 hours after the study. You make the diagnosis in real time. This is another triple negative. Again, it looks fairly benign on the ultrasound, but tremendous deoxygenation and lots of polymorphic internal vessels, tremendous increased hemoglobin within the lesion, even though it looks fairly circumscribed and reassuring on OA. On ultrasound in the left upper image, you can see how polymorphic and suspicious the vessels are. This is another large luminal B, and this is a small luminal A. Thank you.
Hello, everyone. Thank you for viewing the session. We will go ahead and start some questions and answers. If you do have some questions, please go to the bottom of the control panel and click the Q&A, and you can go ahead and ask your questions there.
Okay, can you hear me? Can everybody hear me?
Yes, we can hear you.
Okay. I apologize for the frame rate on those videos. The frame rate is much faster than that, but at least down here in Brazil where I'm sitting, it was windshield wiper slow. The frame rate is not that slow. It's a transmission problem, I guess. The original video wasn't that slow either. So I guess coming 5,000 miles or 7,000 miles from California, it slowed down a little. And probably I see there are people from Australia and India and South America and Europe. And so I imagine other people saw a slow frame rate. So I'm looking at the questions. Marty Pagel asked the first question. I've heard that OA has light fluent spectral coloring issue. Does this affect the total hemoglobin map? And how does this affect the relative map that is a relative measurement? Now, all the maps are relative, okay? Or the colorization maps are relative. The 3 color maps are color relative. Actually, the 2 are, the OA relative and the OA combined. So what I told you is generally true. Arteries are going to be more oxygenated in green. Veins are going to be more deoxygenated and generally colored red. Tumor vessels are generally going to be more deoxygenated, neovessels, and be displayed as red. But if you have a real strong color signal, whether it's real or artifactual, of one color, it can cause colorization toward the opposite end of the spectrum. So if you had a real strong red signal, it could cause veins or tumor vessels to be colored more green than you'd expect them to be. Or if you had a really strong red signal, it could cause veins to be caused, a red signal that wasn't a vessel. It could cause veins to be colored green. It does not affect the OA total map. In fact, the OA total map is the best map to see peripheral radiating vessels, because if you have, the way we create the color is above the line and below the line. So if we say that deoxygenated is above the line and colored red, and green is oxygenated below the line, if you get a green vessel and a red vessel in the same voxel, they cancel each other out. And so you can't see them. And what I told you about peripheral radiating vessels, oh, I should turn my video on, I guess. What I told you about peripheral radiating vessels is that they're often paired. And so you have a parasitized native artery next to parasitized native vein. So sometimes we can't see those on the green and yellow, the green and red maps, because they lie within the same voxel and they cancel each other out, but they add up together on the OA total hemoglobin, the left lower yellow map. And so we will see peripheral radiating vessels on the yellow map that we don't see on the green and red maps. And they will look twice as wide approximately. So even when they're not obscured because of volume averaging in the same voxel on the red-green map, they look wider on the OA total map, the total hemoglobin map. So again, colorization is relative. We can't give you an O2 sat. Diffuse optic tomography can give you that, but it has terrible spatial resolution. Radiologists are visual. I will take spatial resolution over being able to quantitate O2 sat all day, every day. Another question for Marty: what is the depth of view of this instrument? So the depth of view in OA, the default setting is 4 centimeters. But there's an advantage in the medial breast. Many times it's only 1 centimeter to the chest wall and 2 centimeters to the lung. There's an advantage to decreasing your depth to 2 centimeters in those cases because you can get some colorization in the lung and in the chest wall, and that can change the colorization in the breast. So what you want to do is minimize the amount of non-breast tissues in your field of view. What about the depth of penetration? We can penetrate about 4 centimeters through fat. It's a little less through fibrous tissue because fat is more translucent. If you put a flashlight on a fatty breast, it'll shine through it. Put a flashlight on a fibrous breast, it won't. So fibrous tissue is less translucent to light. Laser is light, so it's going to be it's going to be affected like a flashlight. So we can get about 3 centimeters to a fibrous breast. Now, in the Pioneer study, we had 1,757 masses, and we measured the depth to the chest wall in all those cases. And in 95% of the cases, the breast was less than 3.5 centimeters thick. So, or 95% it was less than 3.5 centimeters thick. There were only 5% it was more than 3.5 centimeters. But that didn't mean that OA couldn't work, because you really only have to see the anterior half of the mass. So if you had a 5 millimeter mass at the chest wall at 4 centimeters deep, maybe you could get a false negative. But if you had a 1.5 centimeter mass with a 4 centimeter deep chest wall, 1.5 centimeters of that mass is, only 2.5 centimeters deep. And you can make a diagnosis from just the anterior half of the mass. So you'd only need 3.25 centimeters penetration to get the front half of that mass. So we've got many cases where the diagnosis is made from the front half of the mass. And that brings up another point. Anytime there's acoustic shadowing, there will be opto-acoustic shadowing. And if there's opto-acoustic shadowing, you won't be able to see angiogenesis or deoxygenation with OA. And that's part of the reason that the boundary and peripheral zones work better, because at least half of the boundary zone and half of the peripheral zone is always anterior to the acoustic shadowing. So it's completely unaffected by acoustic shadowing. And so I think that's a big reason that the external features seem to perform better than the internal features, the effective acoustic shadowing. Okay, Zafar, how efficient is OA in not so vascular DABs? So basically, a DAB is what Laszlo Tabar calls ductal adenocarcinoma of the breast, or duct-forming invasive carcinoma of the breast. Most pathologists call it grade 2 or grade 3 DCIS. Grade 1 DCIS never develops stromal angiogenesis. It may develop a little bit of duct wall angiogenesis, but that degree of angiogenesis is too small for us to see. So we generally can't see much in a grade 1. Grade 2 and grade 3 DCIS does generate stromal as well as duct wall angiogenesis. So are we as sensitive in grade 2 and grade 3 DCIS as invasive cancers? No. We're about 97.5% sensitive in invasive cancers, and we were about 87% sensitive in grade 2 and grade 3 DCIS, which is in the range of what MR is. So, you know, our sensitivity is less than DCIS, but it's not zero. It's still pretty darn good. But again, we don't expect to diagnose grade 1 because it doesn't generate stromal angiogenesis. Okay, Dr. G. Williams. Constant problem differentiating invasive lobular and radial scar remains. We do treat as possible B3 sometimes. I think that must be the British system. A large core vacuum assisted biopsy, and of course, routine 14 gauge can give easy cancer diagnosis, often performed first. Difficult question. I mean, first of all, we saw no difference in the sensitivity of OA for invasive lobular versus invasive ductal. It's both around 97.5%. So zero difference. We didn't see that many radial scars, but a radial scar that's mostly fibroelastosis isn't going to have a lot of angiogenesis, and it's not going to be very positive on OA. Whereas one that has a lot of associated proliferative change will be difficult to distinguish from an invasive cancer. Now, our Senogram, the decision support tool that we showed you, includes ultrasound findings. So if the ultrasound findings are suspicious, it may prevent you from downgrading with OA in that case anyway. Hope that answers your question. Marty Pagel again. Since your instrument has fast temporal resolution and you mentioned that some fluorescent dyes can be detected with OA, could you perform quantitative DCE OA that could replace? Yeah, we made a particular effort to develop what we've got without contrast. Now, we think that maybe in the lymph nodes there'd be an advantage to that, and perhaps even in modern neoadjuvant. But at this point, we're looking at both lymph nodes and neoadjuvant, again, without contrast. But sure, you could quantitate the way you quantitate. You could use wash in, wash out times, and all those same things you do with MR. It'd be a little slower probably. No, I don't think so. I think our temporal resolution is faster than MR, so we might actually get more accurate kinetics than you can get with MR. Okay, Dr. Williams said I answered his question. I want to show you one thing here. I'm going to bring up the Senogram, if I can get my Chrome to start up. So this is the AI decision support tool. And I got to share my screen. I forgot to share my screen. That wasn't very bright. So let me share screen. Okay, now I'm sharing my screen. Hopefully you can see it. I'll close the question session. Are you able to see, anybody not able to see the screen? Alyssa, are you seeing it?
Yes, sir.
Okay, so let's just say that we've got a luminal cancer. So it's going to have a lot of speculation. That'll be a score of 4. I can click this radio button, but I can bring up the image reference keys. And it's a little slow, but I can say there's 10 speculations. And I can just go to the next feature, and I can say it's got a thick echogenic rim. And it has a regular shape with angles. And it has a heterogeneous texture without calcifications. And it's got partial or weak acoustic shadowing. And then I can go to the OA features and say it has multiple peripheral parasitized native vessels, high peripheral zone score, lots of radiating vessels on more than one side. It's got boundary zone whiskers, which are these short, perpendicularly oriented things. I can go to the next feature, and I can just say, oh, if this is a triple, the typical luminal A, it's probably just got minimal internal signal, so it's going to be false negative on the inside. Going to have pretty low scores. I'll just give them all ones. And then I can put her in her mammographic BI-RAD. So let's say she had some speculation or architectural distortion. She's the average age of 57. And it's an average size of say 1.3 centimeters and 1.5 centimeters deep. And when I get all 14 of those features entered, the 5 ultrasound features, the 5 OA features, then it's going to give me my blue circle is the mean predicted likelihood of malignancy, and these brackets represent the 90% confidence interval from the 5th to the 95th percentile. So you can see this is up right on the border between high 4C and 5. Now, if this were, let's just say it's an irregular fibroadenoma, so we'll just say that it's partially circumscribed. We can't see complete capsule, but it's a little irregular in shape without angles. It's got homogeneous texture, normal sound transmission, and it's got normal peripheral radiating or normal vessels that aren't radiating. It's got capsular vessel. It's got normal branching internal vessels. All right. She's going to have, maybe she's too young for a mammogram. Well, let's just say she had a BI-RADS 3 mammogram, or 4. Let's call it a 4A mammogram. She's going to be younger. Let's say she's 40. Maybe it was picked up in ultrasound screening, so it's going to be less than a centimeter. And she's pretty small-breasted and thin. So this part of the output bar is false negative rate. This black line represents a 2% false negative rate. Everything to the right of that is the predicted likelihood of malignancy. Everything to the left of that is predicted false negative rate. Each of these 3 little hash marks is 0.5%. So you can see that the 90% confidence interval is so narrow that the 5th and 95th percentile are abutting on each other. You can only see a single line, and the mean is down around 0.1% false negative rate. Now, in the 3 studies that we did, Pioneer, Maestro, Reader 02 study, we allowed the readers the opportunity to subjectively down classify masses to BI-RADS 2 if they really thought it was benign. But the published rate of false negatives in BI-RADS 2 for ultrasound and mammography is somewhere in the 0.2 to 0.5% range. So in no case were they able to achieve less than 0.5% using subjective. But this is a very objective and precise tool. And so in the Reader 02 study, 703 masses, or 703 reads of masses, came up with a predicted false negative rate less than 0.5%. And 700 of those were benign, so the false negative rate was 0.4%. So when the centigram predicted less than 0.5% false negative rate, it actually was less than 0.5%. Well, what's the importance of that? Well, in BI-RADS, we're not supposed to, probable fibroadenoma or complicated cysts should not be called BI-RADS 2 on a baseline. You have to follow them for 2 years to 3 years and make sure they're stable and don't develop any suspicious features before you can down classify them to BI-RADS 2. But if you actually have a tool objective and precise enough to predict a false negative rate below 0.5%, could you consider using ultrasound and OA together, assigning a BI-RADS 2 on a baseline? So it raises some interesting questions. It also, let me ask a question. Does anybody out there have a size or an age limitation above which you cannot classify something as BI-RADS 3? This patient is 40, and it's showing that, she's got such a low rate that, it's about 0.1%. What age would she have to go to before this would not be BI-RADS 3? Well, at 50, it's maybe 0.2%. At 60, it's maybe 0.3%. At 70, now it can't. Now it's about 0.6%. At 75, now it's BI-RADS 4A. But you don't have to have stupid rules about size or age. This takes size and age and mammographic BI-RADS and ultrasound features and everything into account. So, you can see that 40 would be a wrong choice in this, or 50, whether you're arbitrarily at an age of 40 or an age of 50, above which you can't call something BI-RADS 3. You don't need to have goofy rules like that. All right, any other questions? I don't want to keep you any later.
Dr. Stavros, how quickly are results made available from the point of scanning to when they appear on the radiologist console for interpretation?
As fast as your ultrasound shows up. I mean, these are big video files when you're storing video loops. So is it going to take longer to get to the workstation than still images? Yeah. If you got a 1 megabit intranet, you're going to have a problem. But if you have a 10 megabit or 100 megabit intranet, you're not going to have any problems. It'll show up fast. But the video, even ultrasound videos are larger than ultrasound still images, and we believe videos are absolutely critical to doing this properly. Any other questions?
Okay, I don't see any other questions coming in.
I'm going to make one other comment here.
Yeah.
I'm going to show you the ROC curves for the ultrasound features. So, we got rid of, I was on the BI-RADS committee 5th edition, and unfortunately I couldn't stop it. We took the boundary zone out, but look at the area under the curve for the boundary zone versus echo pattern, posterior features, even shape. I mean, shape is pretty good, but boundary zone beats everything. And then when we look at the ROC curves for OA, same thing. The 2 external zones just kill the internal zones. And again, there are 3 reasons for that. I already mentioned acoustic shadowing. Acoustic shadowing will cause optoacoustic shadowing. It'll adversely affect the internal features, but it won't adversely affect at least the anterior half of the boundary zone and peripheral zone features. But also, luminal A grade 1 cancers have a lot of fibrosis in the internal zone. That doesn't require any angiogenesis, so they often don't have angiogenesis inside, but they do in the boundary zone, the peripheral zone. And then grade 3s are often liquefied or hemorrhagic or necrotic inside. And so grade 1 and grade 3 can have no vascularity inside because of fibrosis or necrosis. I think that's all. I don't need to say anything else.
Okay, then
there are chats there. Should I look at chats? There's more. Let's see, is there another?
No, that's not, there's no questions there.
Okay, all right.
Okay, so that
Thank you all.
concludes our session. Thank you everyone for attending. And again, you will receive a recording of this webinar if you would like to review it again. Thank you.